as we discussed last time, rather in the beginning, that cardiovascular system is composed of three components. First one is the heart itself, then the blood vessels, and third one is blood itself. So our today's discussion is about the drugs that affect the blood. First one in this group that are called antithrombotics. The second one is called Hematinics, and the third one is called anti-hemorrhagic
agents.
Two are anti, they will block certain activities in the blood, and one is hematinic, it will promote the production of the RBCs, so they are called hematinics. As you already discussed in pathology about thrombus or clot formation. So clot or thrombus can be formed anywhere in the body, and the problem happens when it increases in size. And as I was looking here, your discussion with Dr. Fathi, so definitely you know about atherosclerosis.
Yes.
Are the accumulation of the lipids in the blood vessels, and even he wrote the drugs which are used, statins. These are the lipid lowering drugs, anti-inflammatory as well as lipid lowering drugs. This thrombus can be problematic when it leaves its site and it travels to lungs, or when it travels to the brain. And then what happens? It is called embolus. Thrombus, when it leaves the place and it travels, that what we say the breakaway part, it travels to the lungs or it travels to the brain, and you see sometimes stroke. Sometimes the patient get hemiplegia, paralysis. So one of the reason because there is some clot that goes there and it blocks the blood vessels in these organs. So that is thrombosis, and we will discuss three different groups that can help to reduce, to prevent the formation, or even to break down the thrombus. So first group in this antithrombotics, these don't make your blood thin. Inshallah, when you will reach 4th year, starting attending your clinics downstairs, and then even inshallah in your practical life, many times you will listen the word from patients as well as from your doctors that the patient is on blood thinners. The patient is on blood thinners. This is layman terminology. That means that these drugs will make the blood thin. But there is no drug that makes your blood thin. You know that blood is always thicker than water.
Yes.
So they just prevent clots from forming or getting larger. What I told that the drugs which are called antithrombotics, they have two functions. either they will prevent the formation of the clots or breakdown of the clots or prevent them from getting larger. So you will see many patients in your clinics, they will be using these drugs for lifetime. Like, I think you must have someone in your community having stents in the heart. You know stents in the heart. If the heart is blocked, they insert from outside a stent to open. So these patients, they need these anticoagulants or antiplatelets for lifetime. They need to take, like you might have heard about bypass surgery of the heart. Someone has undergone bypass. So again, this patient needs these drugs for lifetime. Drugs prevent clotting, what we say pathological thrombosis, by reducing coagulability of blood are called anticoagulants. Pathological thrombosis. One thrombosis is physiological. What is physiological thrombosis? Like normally boys don't work in kitchen, but some boys like to work in kitchen, or some like to become cook, just not professional, amateur, like to cook maybe kabsa or biryani or some other thing. So you cut your finger in the kitchen while preparing something, and the blood starts to bleed from your finger. But you see, after some time it stops. If the cut is not deep, minor cut, after some time bleeding stops. Even while you are playing in your secondary school and you get injured, many times you don't need stitches. You fell down during football or other game, you just start bleeding from some portion of your leg or hand, but still it stops after some time. Why? Because what we say, this is physiological thrombosis. The clotting factors which are responsible to help us to prevent bleeding, they get activated. I don't know whether you discussed in physiology, intrinsic pathway and extrinsic pathway. Whenever there is, you see, small clots are always formed in our body. Like I fist like this, there is trauma. So what will happen? That in response to this, there will be clotting factors, they will come to this area. There will be platelet activation, they will come to this area. Although there is no bleeding, nothing, but I just made trauma to my blood vessels. So these factors will come and they will try to prevent this damage. So that is called physiological thrombosis. So these, they will come, platelet will come, they will make aggregation, plug will form, fibrin mesh. This is called fibrin mesh. So fibrin mesh is formed, bleeding stops. But sometimes you see the wound is deep, God forbid, like in accidents, and bleeding doesn't stop. So what we do, we send the patient to the emergency. Stitches are given. Why? Because now our physiological thrombosis is not sufficient. It cannot plug. It cannot plug this damage. Even the platelets will come, the clotting factors will come, but still the bleeding doesn't stop. So for that, then we need to prevent it. Now, the pathological thrombosis means that due to some disease, like maybe in cardiovascular, maybe in hypercholesteremia, hypertriglyceridemia, lipoproteins, there is formation of clots in the blood. And then what happens? They're getting larger and larger. And then one day the patient gets maybe myocardial infarction, stroke, or some other cardiovascular problem. Now, if we block these by reducing the coagulability of the blood. Coagulable factors are the clotting factors which are present in the plasma of the blood. They come and they start the process of the coagulation. Coagulation means to stop bleeding. Right. Now we have two types of this thrombosis. One is called arterial thrombosis and the other one is called venous thrombosis. Arterial thrombosis means when the thrombosis is in the arteries.
Arteries.
And arterial thrombosis is fibrin-less, platelets rich. More platelets in the main component of the arterial thrombosis is platelets. Fibrin-less, platelets more. Platelets more. Rich in platelets, fibrin-less in arterial thrombosis. So what we will do, we will use drugs that will prevent the aggregation of the platelets. So that drugs will be called anti-platelets. They will be called anti-platelets. You will see, and definitely someone in your community or family will be using them. Second one is venous. Main component fibrin and less platelets. So they are called anti-coagulant. Okay. Third one is fibrinolysis, or process of fibrin digestion by plasma. Fibrinolysis, the drugs that we use to cause fibrinolysis does not differentiate between arterial thrombosis and between venous thrombosis. Saudi, non-Saudi, maafi mushkil. Fibrinolysis will cut everything. It will attack each and everyone.
Whether it's antiplatelets or anticoagulant.
Whether it is on the platelet, whether it is on the venous or on the arteries. When we give this drug, so you can understand that this is the drug of emergency. Why? Because it doesn't differentiate. Yalla, everyone should go out. That is called fibrinolysis. We will see in the next slide. Okay. D grade fibrinogen or fibrin, they are called fibrinolytic agents. You see, we take in the reverse because this is the treatment. This is the treatment. Whenever a patient gets a stroke, what we say thrombotic stroke, the reason is thrombosis, the patient is admitted in the hospital. First drug that he will receive, that should act on the fibrin. That should act on the fibrin. It will prevent the activation of fibrin. So it will prevent the activation of fibrinogen into fibrin. So that is called fibrinolytic drug. And we have two examples. First one is streptokinase and the second one is alteplase. Streptokinase. Strepto from?
Streptococcus?
Yes, from the bacteria, streptococcus. Streptokinase and alteplase. What they will do, that they will break down the fibrin. It will clear every thrombus. It will clear every thrombus, whether it is arterial or whether it is venous. It doesn't differentiate. So this is the strongest in the anti-thrombotics. If you get question on your exam, which of the following is the strongest in action? Which of the following is strongest in action? So that is fibrinolytic. Because it is a matter of seconds. The moment the patient receives the drug, it will start action to dissolve the fibrin or to degrade the fibrin.
So, doctor, we have two fibrinolytic agents, streptokinase and alteplase.
Yes, there are many, but I just took only two which are commonly used. Mostly streptokinase, but mashallah, Saudi Arabia, Furus Mafi Mushkil, they also use alteplase. Streptokinase is rakhis, cheap.
Yes.
Alteplase may be expensive, 3,000-4,000 real one injection. But still, it's okay. Because it is life-saving. It is
Life-saving.
life-saving. It will save the life of a patient. What is the goal? Eliminate formed clots. What I told in the beginning, that it will eliminate the formed clots, whether the clots are in the arteries
Or
or
vein.
whether the clots are in the veins. Okay? Next group, that inhibit clotting mechanism, anticoagulants, which is more related with fibrin, which is more related with venous thrombosis. So, what is the clotting mechanism? As I told you, that whenever there is injury or bleeding, so two mechanisms start to work. One, that the body start to release the clotting factors. Clotting factors, as you see the name next in this that is used, they are synthesized in the liver. Clotting factors, they are synthesized in the
Liver.
So you see, you might have discussed with Dr. Ali, sometimes liver patients are chronic liver disease, maybe cirrhosis and these, they suffer from bleeding.
There won't, yes.
Why?
Won't close.
One of the reason, because the liver is unable to synthesize clotting factors.
Yes.
And these clotting factors, they are called vitamin K dependent. Vitamin
Okay.
K dependent. You know vitamin K is fat soluble vitamin.
Vitamin, yes.
This vitamin is required in the synthesis of the clotting factors which are synthesized in the liver. Mazboot?
Yes.
So that is the anticoagulants. We have two types. One are parenteral. Parenteral means that they are given by injection. They are given by injection. Heparin, what I told, the name hepa is from hepatocytes, because hepatocytes mean liver cells. So that was derived from heparin, so the name is given heparin, hepatocytes. Heparin is IV injection, intravenous. Heparin is intravenous injection. And the next one, that is LMWH, not BMW. LMWH. LMWH means, Dr. Fathi's favorite discussion, low molecular weight. Low molecular weight heparin. There are two types of heparin. One is natural heparin, that is high molecular weight heparin. And the next one is low molecular heparin. What is the benefit of low molecular heparin? It is given subcutaneously. It is given subcutaneously. The natural heparin or the synthesized heparin, that is given intravenous. We can't give it subcutaneous. What is the benefit when we give the drug subcutaneously? we can give the drug frequently. You will see the patient in your clinic, they will be telling you that especially female patients, I am using this drug for the last 6 months. Intravenous? No. We can't use intravenous for 6 months because then it is IV abuse. Then the drug that is used, enoxaparin. It is used subcutaneous. Subcutaneous. But I told what is the benefit of the low molecular weight? If you get question on your exam, what is the benefit of the low molecular weight heparin? That is that it is administered subcutaneously and we can repeat it for many days. So what I told, like during pregnancy, sometimes female needs to take it for even 9 months. Every day she will receive this enoxaparin. But if it is heparin, almost it is impossible that she will receive IV. So that is the benefit. Here we have also oral anticoagulants. Oral anticoagulants. And the first one is warfarin. Okay, you might have heard its name already. Warfarin. Warfarin is very good anticoagulant. But as the name says, warfarin. Warfarin, I am just joking, the name is not given due to this. It is at war with everything. You know war.
Yes.
Fighting with everyone. Interactions. It has many interactions. First thing. Second, it is contraindicated in pregnancy. Why? Because it is teratogenic. It can damage the fetus.
Teratoma.
Yeah. So, warfarin is oral. It is very good, but we cannot use for some patients, especially during pregnancy. This is first thing. Second important thing about warfarin, we need to monitor the dose. In case of heparin or low molecular weight, the patient doesn't need monitoring. Monitoring or surveillance in Arabic means muraqaba. The patient needs to go to the lab, to Dr. Fathi's lab, every 2 weeks if the patient is on warfarin. If the patient is on low molecular weight, although it is painful because it is injection, even if it is subcutaneous, still it is an injection. But the patient doesn't need monitoring. So that monitoring is called INR, not Indian rupee. It is international normalized ratio. If you see warfarin, next is written INR. You will always see this. Even this question is asked many times in Saudi Health Commission. What is the importance of INR in warfarin? Because we adjust the dose of warfarin based on INR, International Normalized Ratio. That tells us about the clotting time and bleeding time. I don't know whether you perform this practical in first year in medical school or in secondary school. What they do, they prick the earlobe here and then take the filter paper and touch again and again until the bleeding stops. So that is test that is performed. So we see the INR. If it is from 3 to 3.5, okay, acceptable. If it is more than that, not acceptable. If it is less than that, not acceptable. Why? Because less INR means coagulation. More INR means bleeding. So, what is the disadvantage of the warfarin? Although it is very cheap drug, maybe 1,000 tablets, 10 Saudi riyal. But the problem is that we need INR monitoring. that the patient will go from time to time to the lab to check the INR. Otherwise, there is chance for failure. There is chance for failure of the treatment. Okay. Now, to overcome this problem, because who will go every day to the, every 2 weeks, every month to the lab, new drug is introduced. That is called DOAC or NOAC. DOAC means direct oral anticoagulant. Direct oral anticoagulant. Direct oral anticoagulant. They are again many, but we just take one example, and that is called rivaroxaban. Rivaroxaban or rivaroxaban. And you, I think you didn't discuss with Dr. Aman the clotting factors. One of the clotting factor is 10, and X. X in Roman means 10.
10, yes.
It acts on the factor 10, so the name is given rivaroxaban. Rivaroxaban is oral anticoagulant. It is substitute or badil for warfarin, but it is marragani. Right now it is very expensive. Later on, we don't know. Okay, go to next. What is the goal? Prevent progression of thrombosis. Prevent progression of thrombosis. The thrombosis is there, the clot is formed. Now what it will do? It will prevent the enlargement of the clot, especially in the veins. Especially in the veins, because we discussed anticoagulants, they are more effective on the clots which are in the veins.
Rivaroxaban,
Rivaroxaban, warfarin, heparin, or enoxaparin, all of them. They are anticoagulants. Some of them are parenteral, like heparin and enoxaparin. Rivaroxaban and warfarin, they are oral. Next, interfere either with platelet adhesion and or aggregation. Clot formation in the arteries. Prevention of the clot formation in the arteries. Because we discussed that arterial thrombosis is more platelets, less fibrin. So they are used to prevent clot formation in the arteries. Again, there are many now, but we take 2 drugs. First one is aspirin. Aspirin, low dose aspirin. Aspirin is a wonderful drug. Aspirin, low dose. Normal dose, it's not working. Right? Have you ever heard about aspirin? Yes or no?
yes.
What is aspirin? Primarily, what is aspirin?
Antiplatelet.
Primarily, you understand primarily. Basic mechanism of aspirin, for the purpose that it was discovered. Aspirin is one of the oldest drug. You can say for the last maybe 5,000 years it is available. With a different, previously it was plant, but it is available since very long time. Aspirin, acetyl salicylic acid. Primarily, aspirin is NSAID. What is NSAID? Non-steroidal anti-inflammatory drug. The drug that is used to treat what? inflammation,
No.
non-steroidal, anti-inflammatory, pain, analgesic, and antipyretic to reduce body temperature. Again, I am repeating, aspirin is primarily non-steroidal, anti-inflammatory drug. Both, this is the drug that is used to treat inflammation, to treat pain, to reduce body temperature to normal. Here the difference is, when we use it for this purpose, then the dose is at least 325 to 500 milligram. 325 to 500 milligram. When we use it as antiplatelet, then the dose is only from 40 to 100 milligram. 40 to 100 milligrams. So the dose is very low. So what is it called? Low dose aspirin. It is called
Low dose aspirin.
low dose aspirin. When we use it in larger doses, it is still antiplatelet. But when we use it in smaller doses or lower doses, it is no more NSAID. It is no more NSAID. It will not prevent inflammation, or it will not reduce inflammation, it will not reduce pain, it will not treat hyperpyrexia.
Sorry, doctor, can you repeat?
I am repeating. We say aspirin, when we give it in larger doses, it is NSAID. Still in larger doses, it is antiplatelet. But the same aspirin, like here in Saudi Arabia, larger dose aspirin is no more available. You go to the pharmacy and ask the pharmacist, I have fever, and some doctor told me it is very good. It is one of the best NSAID even today. Alone in United States of America, even today, 1 billion tablets are used every year. 1 billion tablets. It is so effective drug. But because there are some problems, some side effects are there, so we want to be on the safe side. You go to the pharmacist, ask the pharmacist, I have sore throat, fever, pains in the body, give me aspirin. And he gives you aspirin 100 milligram. What you will say? Yes or no? No, very good.
No.
Why? Because we know low dose aspirin does not work on COX-2. We will discuss COX-1 and COX-2. Cyclooxygenase enzyme. The enzyme that is responsible for the inflammation.
Yes, prostaglandins.
Prostaglandin enzyme.
Yes.
The enzyme that acts on the prostaglandins. Inflammatory prostaglandins.
Yes.
Cyclooxygenase 1 and cyclooxygenase 2. If it is cyclooxygenase 1 that act on the prostacyclins, on the platelets, if it is cyclooxygenase 2, it acts on the prostaglandin. Okay? So low dose doesn't work on COX-2. Low dose doesn't work on COX-2. So the take-home message that if you have low dose aspirin, it is antiplatelet. And to the extent we say it is gold standard. Gold standard means it is the best choice. It is the best choice. We compare all other drugs with aspirin as antiplatelet. I am repeating again, low dose aspirin is gold standard as antiplatelet.
And high dose aspirin is used for NSAID.
NSAID, but
Yes.
it is still antiplatelet. But we don't use. Why we need larger dose when we get the same benefit from the lower dose?
Yes.
Yeah.
Yes.
So that is important. if the patient, there is one problem with this, that is called ASA, not KSA and USA, intolerance, allergy to aspirin, even with lower dose. Lower dose allergy, lower dose aspirin, and the patient gets allergy. So what we will do, then we will replace it with other drug. And that drug, now we have many, but here I just put one example, clopidogrel. Clopidogrel. This is first instance. Second instance, sometimes you will see the patient is taking both aspirin
And
plus clopidogrel, combination.
Yes.
That means that one drug is not working. Aspirin alone is not working, so we added clopidogrel.
Yes.
But remember, this treatment is not more than 6 months. It is not more than 6 months. After 6 months, we have to decide either take aspirin or clopidogrel. Clopidogrel. Dog is there. Clopidogrel. Both are not taken for longer duration. But for 6 months, yes, we can take both aspirin as well as clopidogrel. After that, we will decide whether we should go for aspirin or whether we should go for clopidogrel. Clear? So, that is to prevent initial clot formation. What I told, clot is not formed, but there is chance that the clot will be formed. Like clot is formed in people who are obese, 40 years, 50 years of age, no problem, but the patient is obese. And you see the patient in your clinic and he tells you, doctor, I am using aspirin. Why it is important for you? Because you know dentists are playing with blood in the mouth. Any procedure that you do in the mouth, there is chance for bleeding. So the patient tells you, doctor, I am not suffering from any problem, but I am using aspirin. So what should come to your mind?
Bleeding.
The patient can bleed. Why? Because it is antiplatelet.
Severely?
Not severely, but it can bleed. Bleeding is always challenge for dentist. Okay? So, what is the most important side effect of all antithrombotics? Whether it is fibrinolytic, whether it is anticoagulant, whether it is antiplatelet, bleeding. Bleeding is the most common side effect of all the three. Okay? So, if you get question on your exam, write one side effect. So, this is for all the three. You can write it for anticoagulant, you can write it for fibrinolytic, you can write it for antiplatelet. Clear? Okay, now we go to next. Hematinics. Hema. Hem means
Blood.
iron.
Iron.
Hemoglobin. Okay, so hematinics, folic acid, vitamin B12, and iron. Ferric. Dr. Fathi's favorite. Now, here one thing that will help you throughout your life. 2 vitamins are important for us. 2 vitamins.
Vitamin K.
Vitamin B12. Vitamin B12. Yeah, doctor. And the second one is vitamin
K.
D.
T.
Vitamin D. You will see, because inshallah you will go to the clinics, to the Noor hospital and other hospitals. The doctors order many vitamins, but only 2 are important. Vitamin B12 and vitamin D. That's it. The rest is rubbish. Okay, now here you see folic acid, vitamin B12 and
iron.
iron. We say they are hematinics. They are
Hematinics.
hematinics. They help to produce the RBCs. Now, who needs to use them? In first instance, we need to understand what is the indication or use of hematinics, where we should use them. Anemia, where is my blood? AN means absence, emia means blood. Where is my blood? Anemia, as you discussed in detail with Dr. Fatih and Dr. Ayman, types of anemia. Types of anemia, if you take blood, put it on the slide, and you put the slide under the microscope. Got my point?
Yes.
And you see that the RBC size is smaller than normal. It will be called? Micro, biology. Microcytic. The RBCs, they look smaller than
Usual.
or than normal. So that is called microcytic anemia. Microcytic anemia is mostly in iron deficiency. Mostly in iron deficiency. As you will discuss today, inshallah, in case we perform HB, hemoglobin level, you might have discussed with Dr. Fatih already. Ferritin. Ferritin is one of another important test that is performed to see the iron level. Okay. Serum iron, total IBC, these are also other tests. You see that the size of the RBC is greater than normal.
In what?
Under the microscope, what I told you, take blood, you put it on the slide, slide,
yes,
put under the microscope, and you see in power 10 or 50, and you see that the RBCs look greater in size. Macrocytic. Macro. M-A-C-R-O. Macrocytic. Anemia. So most probably the reason is folic acid or vitamin B12. Folic acid and vitamin B12. So common clinical anemia is iron deficiency anemia. Common. You will find many patients, they are using these drugs. Very few patients, they are suffering from folic acid or vitamin B12. Yes, they suffer, but they will have comorbidity like hypothyroidism, maybe gastric ulcer, maybe using other drugs. In that case, there is possibility. But most common clinical presentation of anemia is iron deficiency anemia. So that is called microcytic anemia. Okay. Now, who uses folic acid? Inshallah, when you will get married, you will know this. All the females before starting pregnancy or first 4 months of pregnancy. Yeah. Why? Because folic acid plays important role in nucleic acid synthesis. Genetic. If the patient doesn't use, there is possibility for neural defects. Neural defects can be possible. So this is prevention. Folic acid is must during first 4 months of pregnancy for females. Okay? Second one, vitamin B12. What I told, that 2 vitamins are important. One is vitamin B12 and the other one is vitamin D. Many times old age patients, they will not suffer from anything, but when you will refer the patient to check vitamin B12, it is very low. So in that case, we use vitamin B12. Okay? Again, the most common one that we use in our clinics is iron deficiency anemia. And for iron deficiency anemia, the treatment is straightforward. There is no if and but. What we will do, we will supplement. Iron supplementation, oral or parenteral. Mostly oral, tablets, syrup, or we can use injectables, IV also. It depends on the situation. Okay, now we have oral ferrous sulfate, as you will see in the today's case also. Most common. It is very good in absorption. It is most commonly used. You can also see ferrous fumarate, ferrous gluconate, ferric citrate or iron 3. Iron 3 or the ferric citrate, it has better oral tolerability. The patient doesn't complain many things about ferric citrate. What are the adverse drug reactions? Mostly metallic taste. But remember, metallic taste is minimum with ferric citrate. It is minimum with ferric citrate. That is the only important side effect that is less. Diarrhea is there, constipation is there, and even blackened stool is there. Blackened stool. You know the normal color of the stool is brown.
Brown, yes.
So, sorry? What is he saying?
Bilirubin.
Bilirubin. Yeah, one of the byproducts. So, you give the patient iron. And very next day, the patient calls you back, doctor, rest is okay, but I am bleeding into the stool. Why he is saying bleeding into the stool? When he Googles and he writes black stool, that means that he is bleeding. Whenever the GI bleeds, the color of the blood turns into black. If it is not fresh bleeding, the bleeding that is in the anus or in the rectum, rest of the bleeding that comes from the upper portion of the GI, when it is absorbed and it goes down, it turns into black, and that is called melena. You might have discussed in pathology, melena. So what you will tell the patient, no, Mabruk, this is good sign. Why? Because more the color is darker or black, it means more iron is absorbed. The most difficult challenge for the iron that we take oral is absorption. Very small absorption. Most of the iron goes unabsorbed from the body. So that is harmless side effect. Blackened stool. Almost always you will see any patient that takes the iron supplement, even the food that is rich in iron, it will turn the color of the stool to black. That is important for us. Parenteral result for complicated anemia patients. A complicated or during pregnancy, last trimester, the patient doesn't take or the patient cannot take, then in that case we take parenteral. The first option to correct iron deficiency anemia is oral iron supplementation, 3 to 6 months. 3 to 6 months. But if the patient for some reason cannot use oral, then we will go for parenteral.
Doctor,
Yes.
one last question. Macrocytic anemia is due to vitamin B12 and folic acid deficiency.
لا ما في macrocytic.
Macrocytic.
Yeah, macro.
Is due to vitamin B12,
B12 and folic acid deficiency.
And microcytic anemia is due to iron deficiency.
Yes. Anti-hemorrhagic agents. Tranexamic acid is one of them. What I told, that you get deep injury or wound and the bleeding doesn't stop. Your own physiological system doesn't work. So what we will do, now we will use drugs that can help us. And this is one of the drugs that is present in every dental clinic, tranexamic acid. Why? We will see it. It is anti-fibrinolytic agent. Previously we discussed
Yes.
fibrinolytic.
Yes.
The drug that promotes the degradation of fibrinogen and fibrin. What does it do? It prevents the degradation. Why? Because fibrin is a mesh.
Oh,
It is a
mesh.
and we want to strengthen mesh to prevent
Degradation.
bleeding.
No, bleeding.
To prevent bleeding. Whenever this mesh is like this, bleeding starts. When it comes again, the bleeding stops. So we want to prevent the bleeding. So how it can prevent bleeding? As you discussed with Dr. Ayman in physiology, tissue plasminogen factor or tissue plasminogen activation. Whenever there is trauma, the body starts to produce different activators. And plasminogen, as you see, plasminogen, it is converted into plasmin.
Plasmin.
And plasmin is like scissor. You know scissor?
Yes.
Magas.
Yes, scissor.
It cuts the fibrin like anything. When plasminogen is converted into
Plasmin.
plasmin acts on the fibrinogen or fibrin and it cuts the fibrin. So what will happen? Like this is mesh and you cut it, so it will come like this. So there is bleeding. So what we do? We prevent the activation of plasminogen into plasmin. How we prevent? Tranexamic acid acts on the lysine receptors. There are lysine receptors on the plasminogen. We block these receptors. Like if you remember, we discussed it in anti-hypertensive drugs, ARBs, angiotensin receptor blockers. They block at the angiotensin 2 type 1 receptors. The same here, tranexamic acid blocks at the lysine receptors the conversion of plasminogen into plasmin. Why it is important? Because plasmin is like scissor or it is like dog. It cuts or it bites like anything. So what you like, dog or scissor? So we block it. We block it. But it is not 100%. I tell you, it is not 100%. Still, some plasminogen is converted into plasmin and it works, but it is not heavy. Okay, so what are the indications of tranexamic acid? First one is HMB. HMB, as you will see in today's case, heavy menstrual bleeding. Heavy menstrual bleeding. So that is the problem of the karam. Males or females? Males? Females. Heavy menstrual bleeding. During menstrual cycle, first phase of the menstrual cycle, 5 to 7 days, some females suffer from heavy menstrual bleeding. So that can be used to reduce the bleeding. First one. Second one is postpartum bleeding. Postpartum. Again, female's problem. After delivery of baby.
Okay.
One of the challenge sometimes is bleeding after delivery of baby. Again, tranexamic acid is very effective. Life saving. It is life saving. Third one, surgery. Surgery. Before surgery, after surgery.
What happens?
This is the best option. Like sometimes some people, they are suffering from hemophilia. There is a condition where there is tendency for bleeding. So, and the surgery is required. So what we do, we give before surgery. And you see after surgery, there is chance for bleeding. Bleeding is always there after surgery, including dental surgery. So, name any surgery: cardiac surgery, neurosurgery, orthopedic surgery, oncologic surgery, any surgery, bleeding, tranexamic acid is very effective. And we have both oral as well as injectables. Next, tooth extraction. Sometimes what happens when tooth is extracted, there is bleeding in the socket, you know socket. So we just take the capsule of the tranexamic acid, open it in the socket and put it, bleeding stops. So it is so effective. Or any other trauma cases. Side effects. First side effect is important. But this side effect is when tranexamic acid is given injection, IV. Intravenous administration, it can cause anaphylaxis. If you remember, we discussed anaphylaxis in penicillin. It can also cause anaphylaxis, but it is not that much severe that it will kill the patient, but it can cause anaphylaxis. Second, it will cause thrombosis. Why? Because it promotes the fibrin. It promotes the fibrin, so it can cause thrombosis, not thrombocytosis. Thrombocytosis means increase in platelets. Thrombocytes are platelets. Here it will cause promotion of thrombosis, whether it is thrombocytes, whether it is otherwise fibrin. GI intolerance, NVD. What is NVD? You will write the full form. NVD.
GI intolerance.
GI intolerance, NVD. N for Nigeria, V for Vietnam, and D for Denmark. These are the three GI intolerance. Nausea, vomiting, and diarrhea. Nausea, vomiting, and diarrhea. It happens with tranexamic acid. That is the story of today's discussion. Antithrombotic, second hematinics, and third one antifibrinolytic. This is very important drug. Inshallah, when you will start your clinics, you will carry all the time because bleeding is always there in dental clinics. Thank you.
Finish, doctor?
Doctor, the last lecture.
Hopefully.